Hello, we are going to talk about my favorite topic, probably, workarounds, which are something that have emerged as very important for health information technology developers in general, as people just don't understand why these people in hospitals in particular are not using the system the way I thought they would. So why are workarounds common with electronic health records, and how can we mitigate risk to patients? A workaround is when a user deviates from what is intended in terms of a work process. It is done for a reason. It's trying to overcome an obstacle by somebody who is responsible to meet a work demand. So it will likely differ from formal processes documented in policies and procedures. In our framework for the National Institute of Standards and Technology, workarounds are there. They're there because if there's a lot of them, that's an indicator that there's probably quite a few use error root causes in the software. So basically, if you see a lot of them, you probably should be thinking about how to redesign your system to enhance it. Common workarounds, what are they? The first one is anytime you add a new step to a work process, it's pretty predictable that the people doing the work are going to find some way to not do that new step, which is going to slow them down, make the process more inefficient, and in their minds was probably not needed because it wasn't there before. So the classic example is having to scan a patient's wristband before giving medications. It's a new step, wasn't there before, and so it's likely that they'll type in a social security number rather than scan the wristband, or scan a wristband that's not on the patient's wrist. So handwritten notes on paper are seen particularly with nurses and physicians during hospital care. One of the major reasons is because then they don't have to find a computer and log into it in order to get information to answer a question that they're asked in the hallway or in a patient's room. So you go into a patient's room, a patient says, when am I due for my next pain medication? And they can immediately give the answer based on the notes that are written in front of them. We see people in the electronic health record taking pretty much any unstructured text field, particularly if it's large, and starting to put other stuff in it. So in the problem list section in electronic health records, OB/GYN physicians were seen putting the fundal height, which is the height of the fetus, inside the problem list area, because then it was easily accessible and there was nowhere else that was designated to put it in the electronic health record. And then you can have these complex annotations on these shared whiteboards. So this is not electronic whiteboards. This is just standard old whiteboards with markers. And they're using that to coordinate scheduling and teamwork. So then somebody will put in an electronic whiteboard and say, why are you not using it? Well, one of the reasons why might be that not everybody has access to that whiteboard. The time to log in is noteworthy, and patients aren't up there until they're entered into the system by the clerk. So you can't write notes on a patient who's not on the board yet. So how do we reduce these negative workarounds? The bottom line strategy is to reduce the gap between what is documented in policies and procedures and what is actually done in the work setting. One of the ways to do this is to make it easier for people to do the intended description of work. Another trick is to put a summary overview display. So much of what is happening with these workarounds is reducing the time to forage around for information dispersed throughout an electronic health record by having these handwritten notes, by having these whiteboards. And so if you provide electronic summary of overview displays, then you reduce the need for people to be creating these overviews on paper or on a wall. The other thing that is clearly needed is to have a better ability to communicate through the electronic health record in a HIPAA-protected way. So these complex annotations on the whiteboard are communicating across the various roles in the medical center and in the hospital. And in part, these electronic health records are sort of by intention designed as individual user activities. So they might say for a nurse, here's what they're going to do. For a physician, here's what they're going to do. But they don't necessarily think about how they can support communication between the nurse and the physician in order to make their jobs easier. So here's a big distinction that helps a lot with thinking about patient safety, which is what is the idealized version of work? That is work as imagined, or WAI. So for the example of medication administration, a physician orders a medication, the pharmacist dispenses the medication, the nurse administers the medication to the patient. That is how we think about work happening in hospitals. But in reality, just a few examples of some of the safety that's being created by the nurse is, let's say there's an automated stop order. So a physician intends to order a medication, an antibiotic medication to address sepsis, which is an all-body infection, and it's meant to be for 6 weeks. But the physician can only order 3 days at a time because of a hospital policy, which is trying to reduce the overuse of antibiotics so that we can have antibiotics 30 years from now that are effective. So the nurse says, oh my goodness, this patient has received 3 out of 6 weeks of an intended antibiotic treatment for sepsis. I'm pretty sure that they want to continue. So the nurse walks by the physician and says, there's an expired medication order. Are you going to renew it? And the physician says, absolutely, I'll get right on it. A similar example is a nurse looks to see what medications haven't arrived yet. I'm just about to go into the patient's room and give medications, calls down to the pharmacy and says, is that medication ready? And the pharmacist says, yes, I'll send it right on up with the robot. So here are examples of hidden work is done that's actually creating safety. Now, how does this relate to the design of health information technology? So when you put barcode medication administration in, if you don't know those hidden safety loops exist, then you can inadvertently cut them. So if you have a barcode medication administration software package for a nurse that does not show pending medications, meaning not yet verified by pharmacy, and discontinued medications, meaning automatically expired orders from physicians, it can make sense when you're designing to think, well, why would the nurse need to see those? There's no desire to administer those medications. Let's clean up the screen by not giving information that's not relevant, without realizing that essentially safety has been cut down in the system for those pre-existing safety checks that the nurse was doing, because now there's 2 things. One is the nurse literally doesn't have the information, so cannot do it. And 2, the software design communicates to the nurse that it's no longer his or her task to do that. And so if the barcode medication administration software was put in to enhance safety, essentially that job of safety was moved from the nurse to the system, and the system isn't doing what the nurse used to do. So you can actually end up with the new work is done being less safe than the previous when the technology was implemented. And this is a choice. It's absolutely a choice. You can show pending and discontinued medication information, perhaps as an optional view by having the ability to click on it. There's no reason why you cannot show it. So how do we make work as intended easier? Anything we can do to limit interruptions, particularly auditory interruptions like a phone call, instead of having a pager, or instead of letting interruptions kind of gather up together before they go out. Anytime we can reduce uncertainty about what is supposed to be done when. Decreasing time pressure is great for making work as intended easier. We can make it a lower consequence if something does fail. And we can also have fewer things that are interconnected together, which increases complexity. We can have less workload assigned. We can increase the flexibility to deviate from the intended workflow. And this is as much to match the work is done as it is to allow what's called exception handling, meaning that when there is a different thing that is needed for an individual, that you have the authority to do that. And then we can always improve the usability of the system. So in conclusion, workarounds can be positive or negative, so they're not always negative. But from a patient safety perspective, we are worried about the negative deviations from an intended process. So many workarounds are done to coordinate when technology is designed for individuals as opposed to teams and interacting roles that have to work together to coordinate patient care. We have negative workarounds reduced when we make work as intended easier to do. And so we reduce the gap between work as intended and work as done. And by reducing that gap, we improve patient safety. Thank you for your attention.